Hi, everyone. My name is Emily McLeod, and I am an advanced practice nurse at Women's College Hospital in the TRS program. I am Zooming from my office in Toronto today. I would like to acknowledge the land on which I live and work, previously and continuously stewarded by a multitude of Indigenous societies, including the Petun, Huron-Wendat, Haudenosaunee, Anishinaabe, Métis, Mississaugas of the Credit, and others. I stand in solidarity with Indigenous people and their right to land sovereignty. Welcome to the last TRS series of 2023. We are very excited about all the advances 2024 will bring. For many, 2023 can't come to an end soon enough. This was a year filled with many challenges and stresses, including the rising tide of hate, violence, and transphobia that trans people are facing. From protests against youth rights to legislation endangering the safety of trans youth, I want to take this moment to acknowledge and celebrate trans, non-binary, two-spirit, and gender-fluid people and communities. We see you and we stand with you all. As we approach the upcoming holiday season, I want to also acknowledge that this can be a challenging and stressful time, especially for the 2S LGBTQIA+ communities. However you decide to celebrate, whether that is on your own or in the company of family and or friends, I hope that you guard your joy and remain safe. Next slide. All right, before we continue, this is just a reminder that this session is being recorded and all participants are automatically muted. We will be taking some questions live at the end of the event, and we'll consolidate common questions to try and answer as many as we can. We'll be reading questions out loud and summarizing similar questions for our experts to answer. Questions can be submitted through the Q&A function that's located in the main Zoom menu bar. And as a reminder, if you want to submit your question anonymously, check that tick box before you send the question. So again, questions can be answered through the Q&A function that's located in the main Zoom bar screen. Next slide, please. The Transition-Related Surgery Seminar Series is an information event intended to provide access to information regarding gender-affirming surgery for transgender and gender-diverse people, as well as their loved ones and care providers in Ontario. These sessions will be approximately 1 hour long. We will hold these sessions every 3 months. Please stay tuned for our 2024 dates and times. And just a reminder to please register in advance if you are interested in any of the sessions. The sessions will be held virtually by the TRS team at Women's College Hospital. The TRS series sessions are intended to provide information on the pathways to surgery, as well as discuss variations in surgical techniques and postoperative outcomes. The goal of the series is to provide prospective patients and their support systems with a deeper understanding of what to expect and how to prepare for their surgical journey at Women's College. Our hope is to maximize the effectiveness of surgical consultations by providing patients an opportunity to engage with the team here and learn about the pathway, the eligibility requirements, processes, and timelines of surgery. We also hope that by attending these sessions, folks will feel more able to identify the areas to address in preparation for surgery, including necessary postoperative care support. Next slide, please. So this is our team. We have 2 surgeons, Dr. Yona Krakowski and Dr. Alexi Millman, who I will introduce in the next slide and who will be doing the presentation today. We have a nurse practitioner, Emery Potter, and myself, an advanced practice nurse. And we also have Olivia Drodge, who is our physiotherapist. Next slide, please. All right, so now to introduce our TRS surgeons. So we have Dr. Yona Krakowski. He is a urologist and sexual medicine surgeon on staff at Women's College Hospital and at Mount Sinai. He is an assistant professor and surgeon educator at the University of Toronto and the vice program director of urology residency program. Yona is the medical director of the TRS program at Women's College. He completed his medical school and urology residency at U of T and has a Master of Education degree from U of T. He completed a fellowship in sexual medicine and surgery at Harvard Medical School in Boston and has been working at Women's College and Mount Sinai since 2018. Yona loves music and every Toronto sports team. We also have Dr. Alexandra Alexi Millman. She is a reconstructive urologist and surgeon on staff at Women's College and at Mount Sinai. Dr. Millman is a surgeon investigator at the University of Toronto with the rank of assistant professor. Dr. Millman is originally from the West Coast, completing medical training and urologic surgery residency at the University of Toronto. She then completed a fellowship in genital reconstruction surgery at the University of Illinois in Chicago. She has a master's in public health from the London School of Hygiene and Tropical Medicine. Dr. Millman is an avid animal lover, loves sushi, and enjoys playing Disney soundtracks during her ORs. Now I'm going to pass it over to our two experts, Dr. Yona Krakowski and Dr. Alexi Millman.
Hey everyone, thanks so much for coming to this seminar, and special thanks to Emery and Emily for making this happen, and for my partner in crime, Dr. Millman, who's sitting next to me. I'm going to say advance slide, but I'm controlling the slide, so I got to figure out how to advance slide. Okay, great. Also, thanks for the photo. We were just joking that was a photo actually taken from my audition for the Smurf movie and not my headshot for medical purposes. I'd love to talk to you a little bit about the history of the program. I know it doesn't give a lot of information about what to expect now that you're in the program, but I think knowing where we came from actually helps us sort of understand where we're going, which is really exciting. So in around 2016, the province changed the approval process for surgery and opened things up by allowing assessments to happen in the community and not necessarily at KMH, which was sort of a bottleneck for assessments. And approvals for vaginoplasty skyrocketed after that. And there was obviously this huge gap in healthcare that affect access, because we had more people that were now eligible to have the surgery, but there still wasn't a surgical center in Ontario providing the surgery. And so folks were going to Montreal or south of the border or even overseas for vaginoplasty surgery. And so Women's College, with a number of partner organizations, endeavored to start a surgical program here in our building at Women's College Hospital. And we'll talk about some of the limitations, because we are an ambulatory surgical center to it. But the positives were, for the first time, we had a hospital system that was really eager to bridge this gap in care. And to provide a surgery that really wasn't available in Ontario for over 20 years as part of a publicly funded system. So it was really exciting. One of the first steps was obviously making sure our building and our program would meet the needs of our patients. And we were very fortunate to have a number of patient advisors that helped us through that process. And while we're continuously learning and trying to improve things, we have come a long way, and the hospital as an institution has as well. Our first cases were actually done with Dr. Marcy Bowers, and people probably know Dr. Bowers. She's actually the president of WPATH right now, and she was featured on I Am Jazz, which was a pretty famous television show as well. And so Marcy actually came to Toronto in 2019. It coincided with two important events in the city, Pride Week, and also when the Raptors won the basketball championship. And so we had this huge parade. And one interpretation was that parade was for the Raptors, but we like to see that parade contextualized as being for the start of our program, which was really nice that 500,000 people came. Our first three cases were in 2019 with Dr. Bowers present, and then we continued after that. And as part of the program, we started with just one case a month. So it would be one Monday a month we would be providing the surgery. This was before Dr. Millman was here. And it was actually just myself and Emery. And we were doing one operation a month. And as we demonstrated that we could do the surgery safely in our building, and that things were going well, we got increased to 2 per month. And then by the time Dr. Millman joined our team, we were doing the surgery weekly. And there's an expression that has come up on previous presentations about our program, which is that we're building a bridge as we walk on it. And it has sort of felt like that from the start. We didn't really have a blueprint. Now, Emery and I, when we started, went to a program in Chicago, and we spent some time at Marcy Bowers Clinic as well to try to understand how those programs function and how we can apply that to our public system in Ontario. But our healthcare system is unique in terms of how things are funded and how things move. And so we've really been maneuvering as we develop in terms of setting up this program and providing access. And I'll tell you an example, because, you know, we see ourselves in some ways as a grassroots program. We really did build it from the bottom up, from our care team upwards. And so on our first operation, which was going to be on a Monday, and we're going to talk more about the surgery shortly, you use dilators in the operating room in order to do some of the reconstruction that we do. And the company that sources these dilators, they're called Sole Source, have two forms of dilators. There's rigid ones, and there's some floppier silicone ones. And we had all of them, but for whatever reason, the ones we ordered to be sterilized for the OR were the non-rigid ones. It was the silicone ones. And I was speaking to Marcy on the Sunday before the surgery, and Marcy says, you know, the only thing that can really cause a problem is if we don't have the right dilators, but I'm sure you got the right ones. And you know, when someone's like, I'm sure you studied for this test, or I'm sure you did your homework. So my eyes kind of did that kind of expression. And I immediately called Emory, and it turned out that the ones we had sterilized may not have been the correct dilators. And it was now around 5 p.m. on a Sunday. It was summer, so it was still bright out. So you still felt like you could do something. And so we immediately realized that we had the correct dilators in Emory's office, but they weren't sterilized. And there also was some security issues in the building getting access. So one of the people that works at Women's College, who's a head of sterilization, also worked at Humber, because Women's College doesn't have the ability to sterilize locally. And so her name is Tara, and she's wonderful. So Emery and I arranged for us to get the dilators at around 7 p.m. On Sunday night before the first surgery from Emery's office. We found out where Tara lived. Tara was an angel and allowed me to drop them off at Tara's house. Tara then drove them over to Humber, got them sterilized, and we got them back at around 3 a.m. in the morning in time for our operation at 7:45. And I tell this story just to give the context that we really, this wasn't a program sort of the ministry gave us our blueprints. It's one that we developed, and we troubleshooted things as we go along, and we're going to continue to do that because that's what sort of our commitment is to this program. And that year in 2019, we had these beautiful signs when we marched to Pride that said we were the first publicly funded transition related surgery program in Canada. And I'm really proud to say that was really only true for a couple months, because soon after, Vancouver opened up their program too, which is fantastic. And, you know, we see the more programs that open up, the better for the community, the better for our patients, the better for access. And so we're excited that we do work with them. This is our picture from 2019. This was our team then, and we I don't have a more recent picture, but we've all aged very gracefully in the past 4 years. And the history of who's on our team has changed a lot too. Right now, we have Emery and Emily, who are nurse practitioner, advanced practice nurse. At some point, we had social work, and we'd love to be able to add that on at some point as well. We have Olivia, our physiotherapist, who is really instrumental. We have many registered nurses that work in the OR, a lot of management actually that have been really helpful that I didn't include here. And then we have our surgeons, and we also have partners in psychiatry that help us along. So we really are developing a robust team, and as we acquire and beg for more funding, we hope that translates into more people working on our team. We would love to expand in terms of different disciplines and in terms of how many people in each discipline. I'm going to do an introduction to surgery, and Dr. Millman's going to talk more about the specifics of the surgery. And the kind of vaginoplasty that we provide here is called the penile inversion vaginoplasty. So I'm transitioning now from the history of the program to the actual surgery. And so the goals of penile inversion vaginoplasty, and I will touch on vulvoplasty, which is a vaginoplasty without depth. I'll touch on that in the next slide. But the goals are to make a vaginal canal with enough depth and width for intimacy and penetration if one desires it. A clitoris that is sensitive, so if someone had erogenous sensation prior to surgery, that they would be able to preserve that with their clitoris. A clitoral hood, so the clitoris is not exposed and not sensitive to clothing. A vulva with labia majora and minora, and we can talk more about the specifics on labia minora because I think that does come up a lot. And like I said before, erogenous sensation. So those are sort of the goals of the surgery. We also offer what's called a vulvoplasty or zero depth vaginoplasty. And what differs from the vaginoplasty in the zero depth vaginoplasty or the vulvoplasty is that there is the appearance of a vaginal entrance, the introitus to the vagina, but there's no actual canal. So it's sort of a blind ending pouch that's usually just an inch or so. And the differences in terms of the surgical techniques is obviously if there's no space in a vaginal canal space, and we don't have to do the surgical part, which is the dissection underneath prostate, which exposes us to the risks of a bowel or bladder injury. And we'll talk more about that when it comes to the surgery. But I would say the big differences between the vulvoplasty and the vaginoplasty is the fact that without a canal, there's no need for dilations. So the post-operative recovery is very different without the dilation schedule, and that there's a change in how we counsel around risks, because without having to go as deep in the body, we don't get as close to the bladder and the rectum, which are potential risks of the surgery. How does the consultation process work? And, as the standards of care change, in general, the province moves slower in terms of adopting those changes, which may be something that comes up as well. But the referrals are generally received centrally in terms of documentation that the primary care providers provide to the ministry for the assessments. And once a patient has had those assessments sent to the ministry, we actually receive documentation from the ministry saying that the patient has been approved for surgery and we can proceed. The first appointment is generally a virtual intake appointment with someone from our nursing team, generally Emery or Emily, to go over the patient's history, the rationale behind sort of our program, the risks and benefits of surgery, and to do sort of the initial intake. And that's usually done virtually. Patients will then proceed to come in person for an examination and to meet with our surgeons, and that could be Dr. Millman, it could be myself, or it could be one of our clinical fellows. And so what a clinical fellow is a fully trained surgeon, oftentimes from outside of the GTA or outside of Ontario, that has come to our program to learn the specific what we do to hopefully offer that surgery elsewhere and continue sort of the plan of increasing access. And we sort of see the fellows are kind of like disciples where they learn these techniques, and hopefully they can open up shop outside of Ontario. So we have what we want, which is more competition, more people providing the surgery, shorter wait times, and better access for everyone. When we see patients, Dr. Millman or myself or our fellows, we do a physical examination, and we do our best to allow our patients to tell us what's the best way to do an examination, because in terms of comfort and in the clinic. And then we have an opportunity to answer any sort of surgical questions that might be about techniques. And of course, we again go over the risks and benefits of surgery. And so hopefully at that point, our patients have had a discussion about risks and benefits for the initial referrals for their assessments, and then with our nurse practitioner, and then again with our surgeons. And hopefully that gives sort of enough opportunity to really address them. It's hard when you go to appointments, especially if you don't have notes written down, it's very easy to forget really important questions that you have. And so the redundancy really allows folks to forget the questions and have another opportunity to get some answers. Now, a really common question we have is, obviously the process to accessing surgery is not as simple as we all wish it could be. And you finally sort of see the surgeons, and it's exciting for many patients. And then the question is, when is the surgical date? And oftentimes we don't actually have that answer during the in-person visit, and we will contact you or whoever once we have more information about wait times and when that surgery will be. And so the expectation is shouldn't be that right away we have a date. It's really exciting. Right now we've gone from once a month vaginoplasty to twice a month to 4 times to 5 times a month, and now we're actually going to be doing twice a week. So we're having an explosion in our volumes, and we're hopefully our wait times will reflect that in terms of being reduced. So some pre-operative issues, so pre-surgical issues. One of our big limitations, and this is one that pains all of us on the care team, I promise, is that we are established in an ambulatory center. So what an ambulatory center means is we don't have an emergency room, and that's not a huge issue, but we don't have an ICU, an intensive care unit, and we don't have, for example, cardiac electrophysiology for some folks with complex heart rhythms or pacemakers. And so there are certain situations right now, much to our chagrin, that we cannot offer surgery in our building. And this is a huge limitation in terms of access for some folks that for medical reasons, we can't safely provide the surgery at Women's College Hospital. And I see sort of two ways forward. One, this hospital can fundamentally change and become an ICU full care center, which is not within sort of the next 10 years. Like that's a huge change, and one that would have to come obviously from the ministry. And the other option would be finding a partner hospital that has ICU and has all the specialties needed that would be able to house our program, whether it be a one-off for operations or as a new second home for us. And this is something that is an issue. It's one that we acknowledge. It's an issue that we've had since 2019, and that we're constantly sort of brainstorming how we can move forward in a way that all patients, regardless of medical comorbidities, can have access to surgery. Some other preoperative issues that come up, aside from people's general health and whether they are safe to have surgery at our institution, is the amount of scrotal or penile tissue. Is it sufficient to create a canal that has enough depth and width? So that's something that we assess at the time of the physical examination, and really why that physical examination preoperatively is quite essential. The cost of the dilators is something currently not covered by the ministry or not covered routinely by our program, but there is wiggle room where we have some funding that can help that situation in some situations. And lastly, discharge planning. A lot of times going into surgery, we think a lot about the pre and the actual surgery, but I would argue that the post-surgical time is just as important as the pre and the surgical time. And we know with a really good care plan post-discharge that allows patients to recover, feel safe, and feel loved, outcomes are better. For sure. The other thing, if one is pursuing a vaginoplasty, a penile inversion, and not a vulvoplasty, dilations are challenging. And having a really good plan of who's going to support you through the dilations, a private space to do the dilations, and how you'll get in touch with us if there are issues is really important. And so part of what will be spoken about at the initial virtual visit, and then reiterated when we see you, either Dr. Millman, myself, or our fellow, is what is the plan for after discharge? And Dr. Millman shortly is going to go over what the actual discharge looks like in terms of how long you're in hospital, when you leave, and when you need to come back. The last sort of preoperative issue that I didn't include on the slide, but comes up a lot, is orchiectomy. Some people have come to our program who've already had an orchiectomy, which doesn't exclude the ability to do any sort of surgery for the most part, as long as there is ample tissue. And some folks come to our program and are interested in maybe an orchiectomy or vaginoplasty, and it depends on wait times. And so for some folks, there is benefit in doing an orchiectomy as a standalone procedure because it is a much shorter operation and the wait times are much shorter for that, and then having the vaginoplasty booked down the road. And it really is unique to each individual, and that's something that certainly we could talk about with you when we see you in our clinic. Okay, I'm going to hand it over to my friend and my colleague, Dr. Millman.
Hi, everyone. Thank you so much for being here. This is such a nice way to share our knowledge with you. So let's talk surgery. How do we change this into that, right? So I'm going to talk about surgical technique. These first pictures are just pictures like this. A little bit later on in the presentation, there are some actual pictures of vulvas. Okay, so we're going to get to that too. I don't have any like really gory pictures, so don't be afraid. Okay, so here, the first picture here, if everyone, I think you can see my pointer, you can see we have the marking of the scrotal graft that we take. So the scrotum becomes the deepest part of the vagina. And so oftentimes people ask us about hair removal preoperatively because there's a concern about hair growth in the vagina postoperatively. And so the area to have the hair removed from is the whole scrotum, and then the first like inch of the penis, if there's some hair there as well. A little bit of hair removal around this area is useful. That being said, our program does not require hair removal. Some programs, I think, are more strong on this subject. We really don't require it. We do some techniques during the operation to try and minimize hair growth afterwards. But no matter what you do, there's always that risk that there may still be some hair growth. Okay, so we take off the scrotum as the first step, and then you can see in this next step, the testicles here labeled as number 5, these are going to get removed. So we take the testicles and all of the blood vessels and everything that are going to them as high up as possible, so you don't feel any of that anymore. And then you can see here we have the penis, and it's been separated from the skin covering the penis. You can see number 6 is that penile skin that's been taken off of the penis. And number 1 there is the head of the penis, which is going to become the clitoris. Okay. And so here you can see the next sort of picture. A lot has happened in this between these two pictures. And so what happens is we separate the urethra from the other components of the penis. So you can see the urethra down here, that's number 10, and it has this catheter in it. And then the erection parts of the penis, those are called the corpora cavernosa, have been mostly removed. And you can see at the bottom here, these 2 circles, number 7, that's like the very ends of them that we just close off. And then this part of the penis here with the head of the penis is saved, and it's saved on the neurovascular bundle. So that's all of the nerves and blood vessels that used to supply the whole penis are now supplying just this part, which is going to become the clitoris. And so you can imagine that that makes the clitoris super sensitive. So it has all these nerves going to it. Up top here, you can see that the penile tube that was here, number 6, now has this additional part, number 11, and that's the scrotal graft that has been what we call defatted, and we try and get all the hair follicles off and everything, and then we attach it to the penile tube. At this part, they don't have like a good picture of the dissection of the vaginal canal space, but that part is done from just below the urethra here. We have to divide, there's all these muscles here, and so we have to divide these muscles. They're called the pelvic floor muscles, and we have to separate them in order to make the space to put the vaginal canal between the rectum and all of the urinary structures, which in the current body sit very, very close together, just millimeters apart. So here you can see now we have, this is a similar picture, but now the head of the penis has been turned into the clitoris, and that neurovascular bundle is getting folded and placed in the suprapubic area, and the clitoris sits right at the level of the pubic bone. Number 10 here is that urethra that has now been shortened and then opened up. So this area down here, number 13, is going to be the urethral meatus, the new opening where you pee from. And then the tissue from the urethra to the clitoris is also urethral tissue. And that forms what we call the vestibule. And it gives like a different color to that part of the vulva. And that gives a more anatomic appearance. What's a little bit different in our surgery than what you see in these pictures here, which I took from this excellent article, is that we also save a little bit more of the skin than you see here that's connected to the head of the penis. So the last like couple centimeters of skin that are close to the head of the penis, we save that skin, we take it with the new clitoris, and that helps us to form a really nice hood for the clitoris. So you can see in this picture here, now this tube, the penile scrotal tube flap, has been inverted. So that's why it's called a penile inversion vaginoplasty, and placed into the newly formed vaginal canal. And then we make an incision in that skin, and the clitoris and the urethra sort of appear through that incision, and we suture everything together. And then you're done. And then it looks like this. So this is a real picture now. So this is what it may look like immediately after surgery. So you have this catheter that's in the urethra. You have some packing in the new vagina. And then you have some suture lines. There's a fair number of suture lines to make everything sort of sit in the right place. Right after surgery, we put this great big dressing on. This is a bit of a pressure dressing. It helps to control the bleeding after surgery and just helps to keep everything in place. So yeah, that is the surgical technique. In terms of the surgical timeline, so I split this a little bit into like a vaginoplasty versus a vulvoplasty. And then in this timeline that you see here, everybody's having their surgery on Monday. Right now, that's the day that we do surgery. Starting in the new year, you may have your surgery on a Monday or on a Tuesday. Okay, so the timeline would be shifted slightly if your surgery is on a Tuesday. So when you have consults with us, we give you tons of information about the preoperative preparation and stuff. But one thing that you're supposed to do the night before surgery in either case is to do an enema so that the rectum is empty. Then on Monday, you have your surgery, and that takes about 4 to 5 hours. If you have a vaginoplasty, on Tuesday, you're on bed rest. And then on Wednesday, you get up and walking and the dressing comes off. And on Thursday is when you leave the hospital. With a vulvoplasty, the stay is a little bit shorter. There's no need for bed rest. So on Tuesday, you get up and walking. And on Wednesday, the dressing comes off and you leave the hospital. And then the next days, I've put home here. Home is not the only destination you can go to. You may go to your home, you may go to your friend's home or your parents' home. You don't want to be home alone. So if you don't have a good place to go after surgery, there is a community support that we can sometimes connect you with to go to sort of an acute respite center where you can have that initial recovery time. So you're home for those few days over the weekend. And then on Monday, you come and you have your first follow-up. And this is when the catheter and the packing, if you had a vaginoplasty, are removed. This is also when you learn to do the dilations if you had a vaginoplasty. So the physiotherapist will see you here after one of our nursing team sees you as well. The physiotherapist also sees you during the hospital. I mean, our team sees you every day while you're in the hospital to help you get up and walking and just check and see how you're doing, how your pain control is, all this kind of stuff. Okay. In terms of the dilation schedule, and we talk a lot about dilations. I know Dr. Krakowski already talked a lot about dilations, but it's because this is really the most important part. You know, we can do everything we do at the time of surgery to make a canal with the best possible depth and width for your body. And everybody is different. And some people's bodies can't accommodate the biggest dilator. It's just not within their sort of phenotype, their body's like ability, their anatomy. But basically we do everything we can at the time of surgery to make a canal with the best depth and width. But if you don't keep up with your dilations afterwards, then the body just thinks that this is a wound that needs to be closed and it will close it down. So for the first 3 months after surgery, we recommend 3 times a day dilation. After that, for the next 6 months, so from months 3 to 9, it's a twice daily dilation. And then from months 9 to 12, it's once daily. And then after you get to a year out, you can often go down to once weekly. Some patients may find that if they only do it once weekly, it's very uncomfortable to do the dilations. It's really tight. And so they might do it twice a week. And I'd say very rarely, some patients just continue to do it once a day because it's easier for them to remember that way. They just make it part of their schedule. Sometimes patients ask, well, what if I'm having sexual intercourse? Do I still have to do the dilations? And the answer, unfortunately, is yes. Like sexual intercourse can sort of replace some of the dilations, but someone's penis doesn't tend to be as rigid as the dilators. And so you just may not maintain the total dimensions that you had at the start if you're only using intercourse as your form of dilation. So we still do recommend you try and do those once weekly dilations, even if you're pretty sexually active. In terms of the dilators, this is a slide that actually you go over in your first visit with the nursing team, but just looking at sort of the depth of the vagina. So the dilators have these little dots on them, and that's how we keep track of if like what your depth is and if you're losing depth after surgery, which is always a bit of a concern for patients. And so if you look at the middle dot, that's to 12 centimeters, which is the average depth of the neovagina, and it's longer than the average depth of the cis vagina. although a cis vagina tends to be a little bit stretchier with sexual arousal versus the neovagina. But you can also see here these stats about the average penis length is only 11 centimeters. And so if we have an average vaginal depth of 12 centimeters, that's pretty compatible, okay? Okay, now we're going to switch gears a little bit and talk about complications. We talk about this so much with you as you come through our program. We really like hammer it into you all. But I think it is important to just be aware of all the possible complications, okay? So there's some complications that can happen with any surgery. These are things like bleeding. As surgeons, when we talk about bleeding, we think about, are you going to bleed so much you need a blood transfusion? We do always get your consent for blood transfusion, but so far we haven't had to give one in our program. Infection, sometimes the skin, like the wounds can get infected, or you could get a urinary tract infection. It's very uncommon. We don't see that a lot. And then any surgery can cause chronic pain or numbness after the surgery. And I think this is just really important to be aware of, because it's something, you know, when we talk about chronic pain, that does mean that it's a pain that may not ever go away. It may be something you have to learn to manage rather than to cure. This really scary, but thankfully rare complications are things like a rectal injury, a urinary tract injury, or injury to the neurovascular bundle. So we can talk about those more. We always sort of talk about these a lot, but a rectal injury basically could result in something called a fistula, which is an abnormal connection between the rectum, where the poop is, and the new vagina. And you could have poop or gas uncontrollably coming into the new vagina. And then a urinary tract injury, it can end up with a similar thing, a fistula between the urinary tract and the vagina. And so you can have uncontrolled leakage of urine into the new vagina. And these can be really challenging to treat. And so luckily, you know, the instance is rare. I think in our program right now, we have a 2% rate of rectal injury and a 1% rate of urinary tract injury. So it's rare, but it's not like it doesn't happen. And these are within the statistics that are presented globally. So, you know, everyone who's doing these surgeries does tend to have some rate of these kind of complications. A neurovascular bundle injury, remember when I showed you the steps of the surgery, those are all those blood vessels and nerves that are going to the new clitoris. And so if this is injured, it could result in a lack of sensation to the clitoris and an inability to orgasm after surgery. And then vaginal stenosis, which I already talked about a little bit. You know, if you can't keep up with the dilations, then the vagina can start to close. And that can also be really challenging to treat. So these are all things that are very challenging to manage, or can be very challenging to manage. And then we have the more common and thankfully generally easier to treat complications. So things like wound dehiscence, which is when the skin edges just come apart a little bit instead of healing perfectly together. This can look really scary, but tends to heal really nicely. And you just have to keep dilating, even though it looks a little bit scary. And you come see us or call us or send us a MyChart message, and we can, you know, give reassurance that it looks like it's going to heal well, or advise you when you may need to be seen. Hypergranulation tissue is a common complication as well. This happens when your body tries too hard to make some healing tissue, and it makes a type of tissue that's really not normal and can bleed easily and can cause discharge. Often it means you end up coming to see us in the clinic a lot, and there's some local treatments we can do for that. The wound dehiscence and hypergranulation, it's about 50% of patients that experience at least one of those complications. Hair growth in the vagina, again, like this is common, that at least there's some hair growth, like, you know, sometimes it's just 1 or 2 hairs, sometimes people have more hairs. We do, like I mentioned, try everything we can at the time of surgery to prevent this, but it's not always completely possible. And then vaginal discharge can occur after surgery as well. And then we always like to mention mental health struggles. I think we are one of the fewer programs that is sort of concentrating on this area. but it is a very challenging surgery, both for your body, like it's a lot for your body to go through, and then it takes a real toll on your mental health as well. You may have been really looking forward to the surgery. You may have put some expectations on yourself about how you were going to feel after the surgery, or expect how you expected the surgery would make you feel, and then you may feel differently, or you may just be really struggling with some complications, and it can be really challenging. And so we do find that up to 20% of patients have some sort of worsening or acute struggle with their mental health afterwards. So it's really important to come into surgery in your best possible mental health, and to have an idea about who you could reach out to afterwards, to make sure if you have a counselor that you maybe already have appointments set up with them after the surgery, to touch base and see how you're doing. So now we're just going to look at a few pictures of outcomes. This is sort of, people are always asking us, well, what does it look like afterwards? So these are some of the vulvas from after the surgery. Like Dr. Krakowski talked about in the beginning, the goal really is to have an anatomic result. So you have the labia majora, you have labia minora. The clitoris shouldn't be visible in this kind of a picture. The clitoris should only be visible once you pull back the labia minora. So there should be a hood to the clitoris. And then you have the clitoris, the urethra, and the vaginal opening. And, like Dr. Krakowski mentioned, the difference between the vulvoplasty and the vaginoplasty, like I couldn't tell you which of these patients has a vaginal canal or doesn't, because the outcome from here looks the same. We do the techniques so similarly between the two surgeries that really from the outside it looks the same, and it's just a question of whether you can have penetrative vaginal sex, and whether you have to then do the dilations to maintain that. This is just another picture of like lots of different outcomes. Everybody's different, so everybody's outcome is going to be a little bit different. And that is the end of our presentation. So now we are going to field some questions, and I think Emily is going to moderate the part. So I'm going to stop my screen sharing.
Thank you, Dr. Millman, Dr. Krakowski. So we do have a few questions. First question for you both is, how painful is vaginoplasty surgery, and how do you manage the pain?
Yeah, sure. Surgeries are painful for sure, and the vaginoplasty surgery can be a painful recovery in terms of actually recovering from the surgery, but also in terms of for folks that have a canal in terms of the dilation. And, when you talk about pain management, for most people, the first thing that comes to mind is sort of pills or injections and things. And we do our best to have a multi-modality kind of approach pain that involves breathing exercises, visualizations, ice, things like that. Of course, in addition to that, we make sure that there are, medical strategies as well. That can include narcotics, include Tylenol, anti-inflammatories as well. One of the really exciting things that we started doing in our program was at the time of surgery. So initially we started adding what's called the pudendal block, which is while the patient is still asleep, we do an injection in the pudendal nerve. And this is a very large nerve that supplies a lot of the sensation to the area. And we are going to be publishing our results there, showing that patients benefited in terms of pain scores and in terms of how much pain medications they needed in the initial period after surgery. And then more recently, we've really been partnering with anesthesia, the sleep doctors, that also have a real interest in pain reduction. And we're offering patients, it's almost like an epidural. It's a morphine that's injected into the spinal cord before surgery, which takes a lot of the pain away in the initial recovery period as well. There's some really good evidence that breaking a pain cycle early on and not letting things get worse and pile on actually really benefits folks long terms in terms of pain. So, those are sort of a number of the strategies. When someone asks, is the surgery painful? If I had to answer a yes or no question, I'd say certainly. All surgeries are. This is definitely a painful surgery, but we do have, many patients that do, really well from a pain perspective post-operatively. And of course, we will do everything possible to manage our patients' pain so they're not at home suffering, obviously.
Yeah. I don't think we've ever had someone who wasn't ready to be discharged because of poor pain control. Like we get the pain under control, and you get sort of on the same regimen that you're going to be on at home while you're still in the hospital, so that you feel ready to go home with that regimen.
Great. Question number 2. Do you need home care after the surgery? Do I need a nurse to come visit me at home after the surgery? So I can answer that from a nursing lens. So you don't need to have home care by a nurse after discharge. What we do need you to have is a support person at home to help with preparing meals, to help with getting pain medication. If you need something that's out of the house, that you need someone to go, because your priority is going to be on rest and recovery. You won't necessarily be able to drive a vehicle or go out to the supermarket to gather those things. So you won't need anyone to do any of the immediate like wound care or dressing changes, nothing like that. You will be going home with a catheter, in which we will teach you how to drain that catheter bag. So those are all things that you will be able to manage on your own. Now, with that being said, we do follow you very closely, especially within the first year after surgery. So we will see you 1 week after surgery. We'll check in with you 2 weeks after surgery, 4 weeks, 3 months, 6 months, 9 months, and 1 year. So you very much will be connected with our team. And if you have any issues or any complications, you can always reach out to our team through the MyChart app that you will sign up through. And if there's anything emergent, then we will discuss that more during those initial consultation periods. But to answer that, you won't need a home care nurse to go home with you. Question 3, how does a program of many CIS providers ensure that they are building trust with and meeting the needs of the TDG community? So I can also answer this. And if Dr. Krakowski and Dr. Millman want to jump in. So we do have trans people that are a part of our team, and we do very much prioritize the training of TDG students to be surgeons of the future. So this has ranged from residents to starting fellowship, and many nursing, research, and medical learners. We very much encourage that into the program and support their training. We do also have 10 patient experience advisors that are integrated into all the work that we do, and very much informs and helps to guide our resources, our pathways, our education, our research. We're also very much connected to our community partnerships with TGD specific organizations as well.
Yeah, that's a great answer. Just to give some personal perspective on that too, I think a really important portion of our program right now is education. And, education has a lot of different forms, but in terms of surgical education, it's, creating environments where people that may not have considered going into surgery feel like they have a home in surgery and feel like they can really thrive as surgeons. And so, we see people, we have research students that are even applying to medical school. We have people that are in medical school that do learning experience with us and get to come to the OR with us as part of their rotations. And we're also heavily involved in the urology residency programs in terms of admitting people to learn to become urologists. And there's been a big change in the past around 7 years, I guess, since I started sort of in the admissions and stuff like that, where we are getting more diverse applicants. And it's sort of our goal and our job to create surgical environments where students that may not have traditionally felt comfortable in those environments are, and feel like they're at home, and we can train folks with lived experience to be providing the surgery. And so we have really open arms, and we're doing our best to create that kind of environment that unfortunately didn't exist in the past. And we really sort of pride ourselves in the education aspect of our program.
Next question, why can't we all have a consultation with the TRS program before we decide on our surgical center? So I can start with answering this as well. So unfortunately, we don't have the capacity to answer the many people's questions that are there, over 500 plus regarding the surgery. We do training with healthcare providers in order to build capacity in the community, so that these can be some ongoing conversations with your provider. And able to answer those questions. We've also built many resources to answer a majority of the common questions that a lot of people have. So please go to our website, and you can see those resources and look through them. And I just want to mention those resources were also built in collaboration with our patient expert advisors, and with the community and patient experiences. So the TRS series is also another great opportunity to answer any questions that many people might have. Next question, is the foreskin used or just discarded in the surgery?
Yeah, it's a great question. So the foreskin is used, sometimes not all of it, but we use a lot of it to form the clitoral hood and part of the labia minora. And so if you're uncircumcised, yes, we absolutely use some of the foreskin. Sometimes that tissue isn't like stretchy enough or wide enough to be used to form the vaginal canal. It won't fit around the dilator. So if there's like a lot of foreskin, then sometimes we trim some of it, but we use what we can.
Do you have any thoughts regarding the pros and cons of different procedures other than the one that's done at Women's College? So any others than the penile inversion technique, specifically the soup porn technique performed in Thailand?
Yeah, I think we could probably spend an hour talking about the pros and cons of different techniques for sure. But I will say this, the folks that come back from Thailand, the ones that we're exposed to have had generally really good surgery with great outcomes by really careful, thoughtful surgeons. And we go to the WPATH meeting, which is where all the surgeons sort of get together once every 2 years. And we're always sort of humbled to be in the presence of such great surgeons that have demonstrated such great outcomes over the years and that have really been committed to moving the field forward. I think one of the upcoming questions is going to be about, what have we done to, or what are we going to do in the future to develop better techniques? And so we're constantly thinking about that, and we're constantly collaborating with other surgeons in the States, right? And so, some of the questions, these are future questions too, so I'll try to knock them off at the same time. Is in general, there's a lot of talk around the peritoneal pull-through method, which is using peritoneum to form part of the vaginal canal. And generally in America where this is done, it's done with a robotic surgery. So keyhole surgery using a robot's arms inside of the patient. And that's currently not a technique that we're doing in Toronto. If we fast forward 10 years and you asked me to bet, I would bet that we would have moved towards that in some situations, although we do think, and the general consensus out there is that the penile inversion technique is a really safe and effective and well-studied technique for the vast majority of patients. So a sort of long-winded question, but we have a lot of respect for the colleagues that are providing this in programs with good volumes that are patient-centered. And it's always nice to hear patients that may see us for other reasons come back and say they had a really good surgical experience elsewhere that really affirms what we're doing in the community that we're part of.
What problems will lead to hair growth within the vaginal canal? And do you recommend laser or electrolysis before surgery? Is it possible to do hair removal after surgery?
Yeah. So I think the general recommendation, although there's really very little research in this area about what is best, is that electrolysis is preferred over laser if you're going to have something done. In terms of problems, I think maybe what the person is trying to say is like, what will be the problems if there's hair growth? So some people just find that it's dysphoric to have the hair growth there. If there's a lot of hair growth, then sometimes that can act as like, things can sort of collect on it, like the lube kind of collects on the hair, and you can get more discharge. It acts as like a bit of a foreign body in the vagina. And so you can get some sort of stuff sitting in the vagina because of the hair growth there. There's not a lot of good options, at least not that we're aware of, in terms of hair removal after the vaginoplasty. We have some patients that come to our clinic every few months and we pluck out the hairs that we see there at their request. But in terms of like a permanent hair removal option after surgery, there's like nothing that we're aware of as a good option. Yeah.
How common is neurovascular bundle injury? Can things be done prior to surgery to mitigate the risk of this complication? And can anything be done about it afterwards?
Yeah, I can address that. So we haven't had a neurovascular bundle injury yet in our program. The reason why that is more rare than a urethral or bladder or rectal injury is just it's a much wider structure. That it's not just sort of one single small nerve. And during the dissection of it, it's right sort of in front of the surgeon's face. So you really have an ability to, it's just sort of a less risky part of the operation. There's nothing from a patient's sort of perspective that can be done preoperatively to mitigate the risks of that happening. But it's of all the sort of the real complications that we keeps us up at night kind of thinking about, that is one that luckily is very uncommon.
Yeah. And I think also the technique that we use, we like save some of the corpora structure to support the neurovascular bundle. I think that's a very safe technique and provides some protection for it. I think as urologists who have many years of experience operating on penises, we're also very comfortable with these structures. And so I think, you know, the risk is low, but it's such a serious complication that we always like to talk about it as a possibility.
What do you recommend in terms of time off work or focus on healing and dilation?
Yeah, 3 months. 3 months is really what we recommend. You shouldn't have any other major commitments for the first 3 months after surgery. The dilations, the 3 times a day dilation really takes a lot of time because it can be uncomfortable, it's messy, you're still learning how to do it. And so it takes up a lot of time, and you know, you're just still healing. Like we mentioned, a lot of people have some element of wound healing complications. And so we do recommend a full 3 months off if possible.
Who is performing the surgeries at Women's College Hospital?
We do them together.
Yeah.
Dr. Krakowski and I try and do all the surgeries together. It's actually like a pretty big team. So it's usually the both of us and then our fellow. We often have a resident, medical student, sometimes a pelvic floor physiotherapy student will come to observe the surgery as well. They're not performing any surgery, but oftentimes there's a lot of people there on the day of your surgery. But it's Dr. Krakowski and I who are sort of jointly in charge of performing the surgery.
What are the wait times to get in to see you for a first consult? So I can answer this. So OHIP approval is now anywhere from 1 to 7 days in a lot of the majority of the cases. So it has moved along quite quickly. And then the referral will be made to us. And then typically we will see you within 1 to 3 months of getting that referral. So it can actually happen quite quickly now. Next question, do you see patients who have had surgery at other surgical centers? So I can also answer that, yes, in our postoperative care clinic. We do have limited capacity. We do work to increase the capacity for patient providers and teach them to manage these complications in the community setting. But to answer that, we can see anyone that's had surgery elsewhere. Next question is... we might have time for a few more. Is Women's College Hospital equipped to deal with complications and revisions such as fistulas, sprain, oversensitivity, and cosmetic related concerns?
Yeah. So we are starting to do more of this. For a long time, we weren't really doing revision surgery, and then we've just started doing that. So for most revision surgery, we do feel comfortable. Like a lot of, there can be sort of urinary issues, cosmetic issues and stuff. We feel quite comfortable. We, for some canal revisions, we can do them. It depends on the issue. So if the issue is more like a shortening of the canal, that may be hard for us to manage here. And, we can do an assessment and we may recommend that what this patient needs is a peritoneal vaginoplasty to augment the canal. And then we don't have the equipment to offer that here. For complications or revisions that are purely cosmetic, that's not covered by OHIP. So we talk a lot with the patients about what they what they're looking for, what they're interested in, and we may be able to offer it, but it's not covered by OHIP if it's a purely cosmetic issue. But for functional issues after surgery, for most of them, we are able to offer the surgery. Here, it's usually like a very small day surgery. You go home the same day.
Last question, is urination of a vagina post-vaginoplasty similar to that of a non-vaginoplasty vagina? Are there extra precautions we might have to take if we do have vaginoplasty with regards to urinating?
Yeah, so the initial period after surgery, there's lots of swelling and inflammation. And so while the goal is to be able to sit and comfortably urinate into the toilet bowl, of course, that may not occur right away. And so it does take some time for the swelling to come down and for the urethra and the area around the urethra to heal, for the stream to be sort of a solitary single flow and into the toilet bowl. But certainly after that recovery period, the expectation is for the urination to flow into the toilet bowl to be able to sit very comfortably and urinate. Nothing sort of preoperatively would lead to, improving those outcomes other than, regular things that are good for the bladder. We know there are a lot of things like coffee and alcohol and spicy foods that can irritate the bladder. And while coffee and spicy foods are really important to me, for example, I would never stop them. Those are bladder irritants and may have a factor in one's recovery if they're, taking lots of substances that irritate the bladder.
Thank you so much, Dr. Krakowski and Dr. Millman, for the very informative talk. Appreciate your time. Thank you everyone so much for coming for today's webinar series. Please check out our website for any information on the next TRS series and for our resources and documentation. Thank you so much.
Thank you all so much.
Thank you. Thanks, Emily.